Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. All right, good evening, John. How are you doing?
Good evening, Jay. Doing great over here, man. How about you? We've got summer rolling full speed.
Yeah, we do here too.
We're encroaching 100 right now.
Oh, okay.
Day.
It's only
nice,
in the 80s
hot and
here.
Humid. Oh,
yeah. But it's a dry heat.
Oh, don't rub that in. Good gracious.
Yeah. Well, good. Well, it's been a month since we've gotten together to do this.
But guess what? It's been a month, but there's brand new drugs coming out, Jay. And
every month, they just don't stop.
They don't stop. And guess what, fellow colleagues out there? You got to know what to do.
Mm-hmm.
When that patient comes in on 5, 10, 15, 20 different drugs, you've got to be able to go through that medical history and decipher all of that. What if they are taking 3 drugs for one disease state, 3 drugs for another disease state? Is the treatment you're about to render going to affect this patient?
Yep.
I mean, should it be a shortened dental treatment? Should you have a little IV sedation involved? These are questions, Jay, we all got to ask ourselves because the population is getting older due to advances in medicine and surgery.
Yeah.
Okay. And medications. All right.
Yeah.
That's what we're here about. All
people are living longer. 80 is the new 60, right?
Right. And guess what? These people want great dental care.
Yeah. Yeah. I've got patients in their 80s that come in that want implants.
Right. Oh, same here. And guess what?
They're losing their first tooth and they want to replace it with an implant.
That how you like that? Their first tooth, and they want to be comfortable.
Yeah.
All right. They come in nervous, because we've discussed this. 1 out of every 3 Americans, I think it's higher. I think it's around 55% are anxious or afraid of the dentist.
Yeah. That's, IV sedation, a dentist who can provide IV sedation to their patients for general dentistry.
Game changer for their practice.
Yeah, exactly.
All right. If you don't have an associate, you will if you switch to IV sedation. You really will.
Yeah. You'll have patients banging down your door.
Absolutely.
All right, so let's begin today's PharmaDocs by thanking our sponsors. Number one is iCor RX.
Thank you, iCor.
Which is a platform for electronic prescribing, which allows you to basically do it from your laptop, from your desktop, from your phone, from your iPad, just about any device.
Yep.
And then Fortune Law Firm, who are there to help you keep your money. They help with taxes, estate planning,
asset protection.
Have
you lectured some with those guys, Jay?
I think I have a couple times. Yeah, they're real good guys.
Great guys.
With Josh.
Yes.
Yep. And then, of course, the Vesper Institute, John and my second home, where we're teaching IV sedation training for dentists.
We want to teach you.
Yeah, and we'll tell you more about it kind of at the end. And then Balance Pharma, which is a company we're really excited about their product that's coming out. It's a buffered local anesthetic in a dental carpule, which will make injections faster acting, but more importantly, less painful for our patients, which they're going to love. Because the acidity in the local is what makes it burn. And if we can buffer that acidity and still have an effective local anesthetic, our patients are going to love it. I think this is going to,
Jay,
change the game with local anesthetic.
Oh yeah. When the fax machine came out, how great it was. Mm-hmm. It was just revolutionary. Mm-hmm. What you just described about Balance Pharma and their product, this is going to be a revolutionary event for dentistry.
Yeah.
There goes the burn.
Yeah.
And
which is what patients hate.
Dentists, you hurt me. I felt the shot.
Yeah. Even with a 30 gauge needle, it hurts because the anesthetic burns.
That's right.
All right, so we've got what, about 6 or 7 drugs today? I can't remember
6 that apply to
6
to dentistry.
Okay, so our first is Myibbin. Mycophenolate mofetil. And this is an anti-metabolite immunosuppressant used for prophylaxis of organ rejection.
And we're going to see those patients come into our office also as well too, because I mean, think about it, Jay, think about all the various organ transplants that we participated in residency.
Oh yeah,
When we did our anesthesia or general surgery rotation.
Yeah, in the U.S. last year there were 46,000 transplants.
Wow.
Every from bone marrow transplants to heart transplants, liver transplants, kidney transplants, you name it.
And their oral hygiene is going to have to be impeccable.
Yeah, yeah. And so this is a drug. It's similar to Cellcept, which has been around for a long time, about 30 years.
Yep.
And this is just a new formulation of it in a liquid that's given twice a day. So it's a little more convenient. The patients don't want an injection or oral suspension. Have to mix that up. So this is basically a liquid formulation. And tissue transplant, like as we said, is becoming more and more common. This drug, of course, because it has significant effects on the immune system, will be of interest to us in dentistry because anyone who comes in with an infection or we're doing any kind of procedure with a risk of infection, we want to make sure that we get these patients covered with antibiotics and do our surgeries precisely and as minimally traumatically as possible. So this is a pretty toxic drug.
Yes,
it actually can lead to serious infections, embryo-fetal toxicity, blood dyscrasias, GI complications, acute inflammatory syndrome, may affect your ability to drive or operate machinery. And then the common side effects are kind of the usual common side effects that you see on every ad on TV for every drug they're trying to push. Nausea, vomiting, diarrhea, infection, vomiting. So those are all higher incidence in patients who are on Myibbin.
And look at all the various organs, and you just said 46,000 last year, and I want to.
And there are 103,000 on the waiting list for transplants.
Yeah,
and
I was going to ask you
2023 numbers. Yeah.
Wow.
Yeah, and from what I saw, 17 people die every day waiting for a transplant.
Unbelievable.
Yeah. They add a new person to the waiting list every 8 minutes.
Jay, what about survivability 5 years after the transplant? Do you know any numbers there?
It depends on the organ that's transplanted or what's transplanted. But it's obviously Myibbin is a very important medication for these patients so that they don't have rejection of their organ or tissue that's transplanted. Really, I mean, the organ rejection is what we call host versus graft rejection, and it's more for the solid organs that have to be transplanted from a patient who's living at the time. So, heart, lungs, liver, kidney, intestinal transplants, pancreatic transplants. It has to be a living donor, someone who's been in a bad car accident, has no chance of survival, has brain damage, etc. That's where the source is. Those are the organs that have a higher risk of rejection. Things like corneal transplants, bone grafting, skin grafting, heart valves, much lower risk of rejection. And you can see here, not only can we transplant solid organs and bone and heart valves, but also, of course, stem cells. And so any patients that has any cancer of bone marrow is going to get a stem cell transplant. And then, so as far as there are two kinds of rejection. One is, mentioned about the host versus graft. There can also be a graft versus host rejection, where especially when they're transplanting liver or any tissue that has a lot of lymphatic properties, tissue in it, where the transplanted tissue can actually reject the host that it's put in, as opposed to the other way around. So that's kind of interesting. Not as common, but it does occur. All right. Next drug.
Look at that. Imdeltra, tarlatamab.
So AMAB. So what does that tell us?
Well, again, it's an immunosuppressant. Okay.
It's a monoclonal antibody.
It's a monoclonal antibody. Yeah. And so this is like what we have said for years since we started talking about UMAB or AMAB. These are immunosuppressants. These patients are going to need antibiotic coverage.
Yeah.
Absolutely. I know. Every time I turn around, I read about more and more about antibiotic stewardship. Okay. I mean, you don't have to give everybody antibiotics walking into your dental office.
No, I never give or rarely give antibiotics like for third molars.
Yeah.
In healthy young patients.
But this is a different thing.
Yeah.
All right. This is a different player. Yeah. All right. And as you can see on the side, it's a first-in-class drug. And so it's bispecific delta-like ligand 3, DLL3 directed CD3 T-cell engager. So it's indicated for those adult patients with an extensive stage in small cell lung cancer.
Yeah.
And the disease continues to progress or after platinum-based chemotherapy.
Yeah. Cisplatin, if it doesn't work, then we have a new drug to treat.
This is a heavy hitter. That's right.
Yeah. And small cell carcinoma, we used to call it oat cell carcinoma back in the old days.
That's right.
And usually most patients that develop this are smokers. 98% of patients who develop small cell carcinoma are smokers, and it's usually not symptomatic until late in the game. And so the long-term prognosis, 5-year survival, has been historically pretty low.
Yeah.
Like less than a year after discovery. And it's a very aggressive, rapidly growing tumor that tends to metastasize. And it's different from the other lung cancers that we know about, like squamous cell, large cell, et cetera, adenocarcinoma. And it tends to occur in a different location also, which we'll get to. So this is a drug that received accelerated approval because the studies were looking really positive, and so they said, well, let's get this to people who really need it, since it's been working so well in our stage 1 and 2 trials. So this is now on the market.
Yeah. And, we were talking about that DLL3, that protein is expressed on the surface of small cell lung cancer cells. And about, as you can see right there, 85 to 96% of the patients. But in healthy cells, it's hardly seen.
Yeah. Exactly. So it targets those small cell lung cancer. Yeah.
And see, that's so cool, Jay, because like I just said, it's first in class and it can target those cells, not affecting good normal cells.
Yeah.
Okay.
And more drugs are going that direction.
Yes.
Using specific treatments, monoclonal antibodies against specific antigens and receptors, really allowing them to pinpoint and target these cancers rather than doing the shotgun approach.
I mean, look at what it says right there. The cytolytic synapse, that's where it results in the formation of that, and it causes the lysis of the cancer cell. I mean, how cool is this? I mean, because normally both cancer is hit, but also at the expense of good, normal, healthy cells.
Yeah, like
not anymore.
Like with platinum therapy.
Yeah.
Yeah, very, very toxic. So accelerated approval, and it showed, let's see, a 40% mean survival of 9.7 months, which is better than with other treatments. And the median overall survival is 14.3 months with the drug, I guess.
And we don't know the future with this. That's why it says the data is yet to mature, because again, with this being the first in class that targets specifically that cancer cell, hey, and we might have people living longer than what you said earlier, because before with oat cell or small cell, prognosis was not good.
Yeah, like I think less than 5% survived a year, and it was more like 7 months. Okay. So it's given an IV infusion over an hour.
Yep.
And it's got a boxed warning for cytokine release syndrome.
Yeah.
And the usual, cytopenia, hepatotoxicity, hypersensitivity reactions, embryo-fetal toxicity, and then kind of the common, side effects: fatigue, fever, dysgeusia is where food just tastes bad, decreased appetite, musculoskeletal pain, constipation, anemia, and nausea. All right.
And see, look that at the very bottom of that slide, it also talked about decreased white blood cells, decreased platelets.
Yeah. Yeah.
And
As a side effect of this drug.
Yeah. So infection and possibly bleeding.
Yeah.
Right.
Exactly. So again, that's another reason why a patient has to be on antibiotics when you do any kind of procedure with them. So the thing with small cell carcinoma is it basically occurs basically in the bronchi.
Yeah.
Towards sort of at the base of the lung and grows from there. And then as we said, it tends to grow very rapidly and metastasize very rapidly too. And there are other types of non-small cell lung cancer like adenocarcinoma, squamous cell, and large cell. Large cell and adenocarcinoma tend to be more in the lung bases peripherally. And
it's late too.
Yeah, and exactly. And lung cancer is the second most common malignancy in both sexes in the United States, only surpassed by prostate cancer in men and breast cancer in women. However, it is the most common cause of cancer death. Number 2 in incidence, number 1 in cancer death. And the incidence is going down in the United States because people are finally realize that smoking is not good for you. They estimate for 2024 there will be 234,000 new cases and 125,000 deaths. But globally, the numbers of small cell carcinoma or lung cancer in general are increasing, especially in developing countries, because much higher percent of the population smokes.
What about vaping, Jay? Because I'd heard once also that in the future we'll see more cancers with vaping, like nasopharyngeal carcinoma, as well as pulmonary cancers, because of the polypropylene glycol that's in it.
I mean, it's just as toxic. It's really no safer. And they said, according to the World Health Organization, they're expecting 2.21 million new cases of lung cancer and 1.8 million deaths from lung cancer. Oh, this is worldwide, occurred in 2020.
Yeah.
Wow. And it's been declining in men. It's been actually slightly increasing in women because it seems like more younger women are starting to smoke, which I just don't understand. All right. Let's see.
Give that habit up.
Yeah, about 70% of patients when they present with small cell lung cancer have extensive disease at presentation. Only median survival of 7 months, and only 2% are alive at 5 years.
Oh gosh.
Yeah. All right. Next we got
Opuviz.
Opuviz. Yeah. A fibercept YSZY, which tells us what?
Well,
it's a biosimilar.
It's biosimilar.
Biosimilar to a drug that's been around for a while for treating this. And basically, it's biosimilar to Eylea for treatment of wet age-related macular degeneration. So not for dry, but for wet. And we'll talk about the differences in a second. Also can be used with retinal vein occlusion, diabetic macular edema, and diabetic retinopathy, which is probably one of the most common causes of blindness in patients with diabetes. But it's not indicated for treatment of in infants who are premature. So it's biosimilar to Eylea, and it can be used interchangeably. So the pharmacy can actually substitute one of these biosimilars, which in a second we're going to tell you about another one, which is Yesafli.
Yeah.
Which is another biosimilar, exactly the same indications, exactly the same everything. And this was based on a comprehensive review that said that these two biosimilars are similar enough to Eylea that there's no clinical meaningful differences, and so they were fast-tracked for approval. Typical warnings are endophthalmos, retinal detachments, retinal vasculitis with or without occlusion, increases in intraocular pressure, and risk of arterial thromboembolic events.
And you know, the thing about it, Jay, as we read the last part down there, there are the first FDA approved Eylea biosimilars.
Yeah.
And they were approved on the same day.
Yeah. Exactly. They're basically identical drugs.
Yeah.
Yeah.
And what they can do for people with, WMD or AMD, hey, more power to them.
Yeah. And common adverse reactions are conjunctival hemorrhage, eye pain, cataract, vitreous detachment, floaters, and increased intraocular pressure. Those are the common adverse effects. So macular degeneration in general is degeneration of the macula of the eye, which is the area where we have the sharpest focus and the most rods and cones, sharpest vision. And cells underneath start to change, and it affects the cells, the receptor cells in the macula, resulting in distortions, dim, everything looks dimmer, reading is not as sharp, everything looks blurry. Sometimes colors look dull.
Yep.
And these patients have trouble adapting to low light. They really have a lot of trouble driving at night, even trouble recognizing faces.
And we're talking about people they know.
Mm-hmm.
All right?
Yeah. They just can't make out the middle of their face.
That's correct.
It's like a big blind spot, or it's all blurry. So they have to use their peripheral vision. Peripheral vision is left intact. But central vision, the sharpest vision, is what's affected.
That's right.
And macular degeneration, of course, is it's not only in diabetics, but it's also seen in patients who are smokers. Again, another disease that related to smoking, as well as people who spend a lot of time out in the sun tend to develop macular degeneration. And so you can see down there at the bottom the difference between normal, wet, and dry macular degeneration. So with dry macular degeneration, you basically, what's happening is as these cells that support the retina are breaking down, they release waste fat deposits that are known as drusen. And this is it basically affects vision. And with wet macular degeneration, it kind of starts off the same way, or can start the same way, but it's a neovascularization of the retina and of the fovea macula rather, with abnormal permeability. And so what happens is you actually get hemorrhage into the area. So you can see on the left there is dry AMD, and you can see all the drusen. On the right is wet macular degeneration, and you can see some drusen, but basically right in the center there, right where the macula is, you see a big hemorrhage.
Yep.
All right, so that's kind of the difference between wet and dry. All right.
Look, clonidine has come out with for ADHD.
Yeah.
Onyda XR.
Onyda
XR.
I guess I'll have to wait for the commercials to come out to know how to pronounce it. That's all when I'm at the gym and I'm watching, on the treadmill, and I'm watching the TV, and with the closed captions, and it's hard not to watch sometimes. All the ads you see are either for prescription drugs or for accident lawyers, personal injury lawyers.
Yeah.
Yeah. And like 10 minutes worth in a row.
Oh yeah.
It's crazy.
Oh,
yeah. Anyway, so this is clonidine being used as a monotherapy for ADHD in patients in whom CNS stimulants didn't seem to be that effective because of their ADHD. So it's the first liquid non-stimulant ADHD medication to be approved in the U.S. and the only non-stimulant medication approved for nighttime dosing. But of course, like any other medication, it can cause some inappropriate behavior, maladaptive behavior. I'm sorry. What am I doing? ADHD, is a common neurobehavioral disorder with onset in childhood. And there are a number of different symptoms, according to the DSM-5, the current Diagnostic and Statistical Manual of the American Psychiatric Association. So inappropriate, maladaptive attentiveness, impulsivity, hyperactivity, but these result in impairment in family, social, school, work, and especially, and to beat ADHD, there have to be symptoms starting before the patient is 12 years old. And most of the drugs have been used, have been CNS stimulants.
What were they doing, Jay, when we were kids? We didn't have these drugs. If we were hyperactive, we were sent outside to play.
They put all the kids on Ritalin.
Yeah.
Yeah. So there are a couple different types of ADHD. As we said, there's kind of the inattentive, distractible, where the person who's affected has difficulty listening, paying attention. They're easily distracted. They forget things. Whereas the impulse hyperactive, is kind of the chatterbox in school, is constantly moving, fidgeting, interrupts others, answers questions before the whole question has been given. And so they can have either type 1, type 2, or type 3, which is the combination of both. And ADHD is a disease not only of children, but also as adults. And the diagnostic criteria are similar, but a little different. For 6 or more symptoms, up to age 16, 5 or more symptoms, age 17 and older, fails to give close attention to details, trouble organizing tasks. These are kind of the inattention, loses things necessary for tasks like their school materials, their books, their wallet, their tools, their keys, their glasses, cell phones. And then the hyperactivity, impulsivity is all the fidgeting and climbing on things and always on the go.
It's like us, Jay. We're always on the go.
I know. I kind of wonder if I have ADHD.
We're nonstop. We're everywhere. We're in the practice doing PharmaDocs, teaching IV sedation. We're always on the go, giving lectures all over.
Yeah. Yeah. I'm like the dog with squirrel. All right. Let's move on to the next
Ekemv. Ekemv. And it's a UMAB, Jay.
Yeah,
I
think this name, brand name needs maybe another syllable or a vowel or two. It's another biosimilar to Soliris for treatment of paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome, which are kind of related but a little bit different. With PNH, there is hemolysis of red blood cells that occurs. I mean, not just when the patient's asleep, but mostly at nighttime, and they will present with all kinds of things like anemia, intravascular hemolysis, thrombosis, bone marrow failure, and the symptoms are fatigue, shortness of breath, as opposed to the hemolytic uremic syndrome, where there's it actually affects the kidneys. Similar mechanism, but also affects the kidneys. And both of them are related to inappropriate complement activation. And in the case of hemolytic uremic syndrome, there are a multitude of triggers. You have listed here the Shigella toxin from E. coli, Shiga toxin, but also it can be from any respiratory infection, Bordetella pertussis, strep pneumonia, influenza, and other viral diseases like hepatitis, influenza H1N1, HIV, Epstein-Barr, Coxsackie-B. Let's see, and also pregnancy and drugs can be a trigger for this. All right, so here again are the symptoms that we see with PNH, which are all related to this hemolysis and lack of basically hemoglobin rather than being carried in the red blood cells, or is carried free in the serum. And so one of the earlier tests for these hemolytic anemias was the presence of free hemoglobin in the patient's serum. So they'll have things like difficulty swallowing, may have pulmonary hypertension because of clots, of the thrombosis in the pulmonary vasculature, dark urine, renal failure, abdominal pain, hemoglobinuria, which we just talked about, big problem with formation of blood clots, thrombosis, anemia, and of course fatigue and ED, all because of this hemolysis of the red blood cells with the release of hemoglobin rather than being transported by the red blood cells like it's supposed to. It's carried in the serum. I guess we're on our last drug already. Wow.
Another
mRESEVIA.
RSV vaccine.
Respiratory syncytial virus, which is, in kids is very prevalent, and it usually has kind of upper respiratory symptoms. So like runny nose, and we tend to see it in like the peaks in the fall and the winter in kids. But it's becoming more and more common in adults, especially over 60. And so now vaccine's been out or RSV vaccine's been out for a few years, but now they're recommending that anyone over 60, even without other risk factors, get the RSV vaccine, especially if they have chronic medical conditions like chronic lung or heart disease, immune compromise, elderly or frail, living in nursing homes. And in older adults, it tends to be more lower respiratory tract than in younger children.
Yes.
So, and they tend to see it in premature infants, those under 6 months of age, and then younger kids, children with chronic lung disease, cystic fibrosis, neuromuscular disorders, etc. Let's see. So it's an injectable IM vaccine. Did you get it?
No, I was going to ask you, have you gotten that? And because I am going to get one of the vaccines out there.
Yeah. I mean, when I turn 60 in 10 years or so, I'll probably get it. Now I got it. And
did you get Prevnar?
I got that one too. I got the flu vaccine, and not a big deal. I'm all up to date on my coronavirus vaccines, although I'm waiting for the new one with the new variant to come out in the fall, so I'll probably get it then. But I hear why. I don't usually, or I haven't so far, gotten any adverse effects from any of the vaccinations. And I think they said it was the Epstein-Barr virus vaccine, the shingles virus. The shingles virus, not EB, but shingles virus, which is a Coxsackie virus, similar to chickenpox, that everyone was saying, well, the first one's not so bad, but the second one will kick you on your ass. And I have no issues with the second one either.
Awesome.
Yeah. So I'm all for being protected against these viruses. All right. So it's a modified RNA vaccine that encodes for the RSV F glycoprotein and induces an immune response and formation of antibodies against RSV F protein. It's the first mRNA vaccine to be approved for RSV and the third RSV vaccine to be approved overall. So symptoms vary, as I mentioned, in adults and children, usually in infants. Irritable, poor feeding, lethargy. They may even have apnea or fever. Whereas in children and adults, you tend to see more runny nose and decreased appetite. headache and fatigue in adults, as well as cough in children also. So more lower respiratory symptoms in adults, more upper respiratory symptoms in children. And here's a little table to determine, are we looking at RSV or COVID-19? When someone goes to their physician with respiratory symptoms. And of course, kind of the big thing is the loss of taste and smell that was kind of classic for COVID-19 is not really being seen in some of the newer variants. Same with skin rashes and swollen eyes. It's more of, just an upper respiratory infection. Whereas the sneezing and wheezing, which see more commonly in RSV,
that's right.
You're starting to see, in some of the newer variants of COVID-19, not so much, but, I'm sure those will become more prominent. Okay. So we're moving on. We're moving tonight.
Yeah.
Why don't you take over with medical emergency of the month?
I like the schematic you put in there, the diagram right there.
Yeah.
I think everybody should already know what's going on in their office, but it can happen because we do clinical procedures that can lead to this, okay?
Yeah.
And difficulty breathing, no movement of air, and the universal sign of choking. That patient is struggling in your office. What's happening? Click.
Airway obstruction. So the things, and it can occur in your office from, maybe gauze that falls to the back of the throat.
Yes.
Patient takes a deep breath in and all of a sudden it's stuck in the airway. Or possibly, a prosthesis obstructing the airway. But most common, of course, is, food obstructing the airway. And you're probably going to see it more commonly, not in your office, but outside your office. And, you need to know what to do. I've actually saved a couple people who were choking. Actually, one of them was another dentist at a conference I was at. So airway issues can occur centrally.
Yes.
Like from stroke, syncope, seizure, medication overdose. Those are going to decrease the respiratory drive, essentially.
Right.
We're talking about more upper airway obstruction with foreign body, somewhat with laryngospasm that we see if a foreign body is irritating the vocal cords, because that is the narrowest part of the airway. And then lower airway, we're going to see other types of issues.
And I mean, so Jay, bronchospasm can occur in an aspiration, like you said, if food comes up. Pulmonary edema, that's going to be a little something different. Let's say if you fluid overload them with IV fluids, that could be an issue right there as well. But, right there, you got a differential diagnosis. Okay, you got an airway problem. What is it?
Yeah.
All right.
So right here, the upper airway, that's where you're going to see choking, where something is obstructing the upper airway. All right. So what do we do? Of course, number one is stay calm, assess what's going on. And again, usually the universal choking sign is going to be a big clue. The patient will be struggling. If they can talk or cough, let them, but stay with them. Let them try to cough it up on their own. That's the best thing to do. But if they really look like they're in distress, especially if they are trying to get attention and they're not coughing, they're not speaking, sometimes they'll try to get attention to get help. Sometimes they'll leave and go to another area, trying to get away from everybody to try to dislodge this themselves. So again, remaining calm is the first thing to do. You may hopefully be able to dislodge whatever is causing airway obstruction, but you still want to call 911 immediately because you don't know how this is going to progress.
That's right, Jay, because, all right, more and more people are getting into implants. Those are small pieces right there. Let's just say you felt like, hey, I didn't need to put a throat screen in, and the implant driver drops back posteriorly. All right, and
it gets stuck. Yeah, and obstructing the airway.
And they're coughing, and then all of a sudden they finally stop coughing, but they're able to talk to you, but there's no implant driver. Did they swallow or aspirate it? Guess where they got to go? The hospital.
Yeah.
they've got to get a chest X-ray, a KUB.
Yeah. Yeah,
Right.
with smaller parts like implants and implant drivers, they're usually going to be able to breathe, although they will be coughing and sputtering a lot, especially if it aspirated into the lungs. So, the airway obstruction is more common with food.
Yep.
And so, first thing you want to do is when you recognize that the person's going to need some help because they're no longer able to cough or speak, is the good old Heimlich maneuver. And of course, that is trying to expel whatever food is lodged by putting your hands together below the patient's xiphoid process and pulling up and back very quickly, exerting a lot of pressure to try to dislodge that object. And you may have to do it a few times. Technique's a little different in children and infants. That's more part of pediatric pediatric resuscitation, so we won't talk about that. But just in adults, the Heimlich maneuver is highly effective, but you usually have to do it a few times. You may get lucky on the first try. I think I remember the one case when I had that dentist at the meeting I was at. I think it took like 3 attempts at Heimlich to get it dislodged.
And CJ, you got to
he was turning blue.
Yeah. You got to him while he was responsive, so you could he was still standing. You could get behind him because when they go unresponsive, that's a different ballgame.
Yeah. Then you got to change your technique.
Oh,
you want to help them down to the ground, to somewhere flat, supine. Where you can do, rather than the Heimlich from behind, you're going to do the abdominal thrust, which is basically the same kind of movement, but it's coming from the front instead of from the back. And you're going to try that a few times, see if you can dislodge the foreign body. And then you want to check to see if you can see the foreign body in the patient's oral cavity. If you can see it, then you may be able to grab it.
That's right.
With a McGill forceps or even a finger sweep. If you can't see it, you don't want to put any instruments in there because you could actually push it deeper and lodge it more tightly. So only if you can see it. And of course, if the patient is becoming cyanotic, and this has been going on for a minute or so, you want to make sure the patient has a pulse, because they can go from, when they're apneic, they become bradycardic and go from bradycardia to asystole or AFib. So you want to make sure that you check their pulse and initiate CPR, BLS, if that's indicated. And that's why.
I was going to say, Jay, I mean, and whether it be if they're still responsive or unresponsive and you're able to get it up, remember now where you've been pressing so hard, there's a very good chance some regurgitation could occur.
Yeah.
All right. So you got to be ready for that with Yankauer suction as well, because now you may have an aspiration issue too,
which you may not have, in the restaurant when you're having dinner with your family, but you turn them on their right side, the rescue position.
Yep.
And of course, you've already called 911 because you may have fractured a rib or xiphoid process and trying to save this person.
All right.
And so they're going to go to the ER to be evaluated. If you are trained surgically, there is a surgical technique called cricothyrotomy or cricothyroidotomy that basically you're going to puncture the thyrocricoid cartilage, which is between the bottom of the thyroid cartilage and the top of the cricoid cartilage. But this is not something you're going to try for the first time. Like in a restaurant or even in your office if you're not familiar. That's why it's so important to call 911 quickly so that they can get there and they have the training to do cricothyrotomy if necessary.
But the thing about it, Jay, in all dental offices, do you really have an emergency response plan to handle this? Because like Jay has said, calling 911 early is critical here because, when we talk about medical emergencies, foreign body obstruction is one of those big 3 that are 3 minutes to live emergencies. You don't have much time when they lose their airway.
Yeah.
All right.
Yeah.
And What if there's going to be this is going to be a chaotic situation in your office, and if you haven't practiced or prepared for it, it's going to be even worse than that. All right.
Yeah.
And who calls 911? You know.
Yeah.
And how do you know it's been called? Because you want the wheels of life rolling to your office ASAP.
Right. And you've got to basically, as John said, a plan and know who in your office calls 911, who in your office goes down and waits for EMS, who in your office is going to call 911 if the person who normally calls 911 is on vacation or out sick. You have to have everybody kind of doubly trained.
Or staff turnover.
Yeah.
All right. Who's going to be that person?
Yeah. So you got to practice these emergencies on a regular basis, like once a month.
Yep.
You can do 1 a month, 2 a month, whatever you have time for. So that's basically all our content. So now we're going to do our shameless promotion of some of our things. On dentallearning.net, we have PharmaDent, which is basically 24 categories of drugs that are obviously older than have been around before what we talk about in PharmaDocs.
Yeah. And if you want a pharmacology update, PharmaDent is what you want, because like Jay said, 15 medication categories, everything, blood thinners, diabetic drugs, asthmatic drugs, respiratory drugs, you know, the list goes on and on. Hypertension, everything.
Yeah, the drugs that your patients are on. I mean, the things that we talk about in PharmaDocs are, you know, you may or may not see patients on those medications because they're so new.
Yeah.
But you will start to see them more frequently. And then getting back to our emergency simulations, we have our DOMES, dental office medical emergency simulations, where we go through, was it 24 different medical emergencies?
Yes. 24. You're including foreign body obstruction.
Yeah.
Right?
All for $99. And you can go back and look at it, watch as many times as you want too, which is nice. You know,
Isn't that
review.
nice? You and your staff, because I've got news for you, colleagues. You can't do this by yourself.
Yeah.
Many have tried and they have failed. All right. Yeah. And you want everyone working together cohesively during a crisis situation in your office.
Yeah. Yeah. And I've shown these modules to my office staff.
Yeah.
And then we practice monthly drills. And then of course our IV station program at Vesper Institute in Cincinnati, Ohio.
Game changer.
Where we train you to learn IV sedation in a way that you will actually implement it in your practice. We go over and above what the minimum requirements are. I think our program's approved in at least half of the states so far.
That's right.
It's a slow process, but we've been approved in almost at least half the states, if not more, so far. And it's partly online and partly in person, didactic, and then the clinical part where you have to do a minimum of 20 cases is actually one-on-one with a general dentist who has been doing IV sedation, and will teach you all the tips and tricks that they know from doing.
Oh, go ahead. I'm sorry.
Just from their experience of doing IV sedation, which is a lot more beneficial than learning from an anesthesiologist or an oral surgeon who's only doing 20-minute sedations. For wisdom teeth, something like that. So it's much more practical for dentistry, because not only are you going to do sedation for quick cases, but also for hour-long, 2-hour-long cases, full mouth rehabs. Those are all going to be on the agenda.
And Jay, the final thing, what sets us apart from other programs is our phase 4, where all of our graduates get with us on a monthly basis, everybody together. We go over a sedation case and we talk about what's happened in your office. I challenge you to look at other programs. Are they doing that as well too?
Yeah.
You become part of the Vesper Nation. You're always going to be our professional student, period.
Yeah. So you go to vesperinstitute.com for more info. And then John's got his pediatric airway emergencies and sedation course, which is also on Dental Learning. That's 3 hours for only $21, $10 per unit. That's pretty cheap. Usually it's about $100. All right. Well, that wraps things up for tonight. Our next installment of PharmaDocs is going to be in July. Can you believe it's June
July.
already?
Happy 4th of July coming
Yeah.
up for everybody.
Yeah, we'll see after the 4th of July. We'll have drugs that have been approved this month in June, as well as a new medical emergency that we will talk about.
Please get the DOMES program. Please do monthly mock drills. I mean, not only will it save the life of a patient, it'll save your livelihood. Because if you lose a patient, on average, your practice is going to close within 30 days.
Yeah.
What will you do? All because a lack of preparedness on your part.
Mm-hmm.
I hear people all the time saying, I can't find a lecture. All you got to do is find Jay Reznick's DOMES 24 program. I mean, it's covered, and you and your staff get to do it. All right. Because many dentists do not bring their staff. I've been lecturing over 20 years on this, Jay, and just the dentist shows
you got to
up.
bring your staff. It's just the same thing with IV sedation. We emphasize bring your staff, because if you take a great course and spend all this money to take the course and you go back to your office and the staff wasn't part of the training, they're going to kind of bitch and moan about having to learn something new.
That's right.
Same thing with implants. If you want to truly implement implants in your practice, take your staff with you to the training. And a lot of the courses that I give and John gives in our Vesper course, we actually have modules just for our assistants.
Yep.
All right. So, John, I guess we'll see you again.
Yes.
In a month.